कर दिए।
Okay, so I'll start off, right? Okay, so good afternoon, everyone, and it's a pleasure to be a part of EN Train, and let me especially thank Dr. Deepak Haldipur sir and Eros for making me a part of this, and especially giving me an opportunity to speak on this topic, which is on cochlear implants, which is one of my most one of the things which I'm most passionate about. And however, the thing which I'm going to talk about is going to be kind of an eye opener, which is talking about the complications of this surgery. Now, why is it especially important for cochlear implants? Because here we are trying to deal with a disability, right? And if we land up with some complication, imagine a disabled person who is already having a lot of issues with his life, landing up with a problem which is going to make it worse for this person. And that is why probably, in this surgery, which if it goes straight forward, it really is one of the most miraculous surgeries which would be there, right? And I love this quote. If it would not have been for nature, surgeons would have been murderers. And this is because, we as surgeons do so many mistakes at times, and nature really helps heal those mistakes, right? And takes care of all those mistakes which are there. And this is what actually prevents us from killing our patients or landing up with bad complications. Now, if you look at the classification for cochlear implant malformations, way back in 1988, we had the Cohen and Hoffman classification. It was like they divided into major and minor. Major was life-threatening complications, some which require surgical intervention, or those which required hospitalization for medical management. Minor were those which may or may not result in decreased performance, resolve spontaneously or with conservative management, and do not require surgery or only small surgery like putting in a ventilation tube, right? So this is how they classified it, and we followed this for a pretty long time. Now, of late, we have the Clavian Dindo classification, which is for any kind of surgical complications. And this is, 1, 2, 3, 4, 5, subdivided into various types, which they have come forward with. For cochlear implants, this is a modified. Type 1 is a self-limiting complication requiring no treatment or simple pharmacological treatments. Type 2 would be complications which require pharmacological intervention other than those permitted under the criteria for grade 1. That would mean a more regular course and a long-term course of medicines, or which may require a non-invasive radiological imaging. 3 is divided into 3A and 3B. 3A is something which requires surgical, radiological, or endoscopic intervention, but excludes implant explantation or reimplantation. 3B, however, necessitates explantation or a reimplantation if possible. So this is what we really follow now. But more important, this classification is to really deal with all these issues which may be present in a cochlear implant complication. Now, the most dreaded one is the facial paresis or palsy, which we all are worried about, right? And if a patient really presents with this kind of a facial deviation after surgery, it really is bad because patient already had, as I mentioned, one disability, and we made the patient suffer from another disability, right? And facial palsy, if you, God forbid, we land up with it, because when you're operating, there are going to be chances when we do have these issues. And all cochlear implant surgeon patients have faced facial paresis. So if we were to kind of divide them to treatment part, the primary or immediate, which if it happens, if it is less than grade 4, we would usually give only steroids, physiotherapy, review the surgical video if there is anything wrong which has happened, and do electrophysiological testing and monitoring. If it's worsening, you may need to do a decompression. If it's more than grade 4, we need to review the surgical video, do the electrophysiological testing. We may need to do, if more than grade 4, facial nerve decompression or grafting. Obviously, steroids and physiotherapy remain a part of it. But more importantly, more than grade 4, immediate paresis, we may need a facial nerve decompression sooner than later. If it's a secondary thing, more than 1 hour after surgery, that's a delayed or a secondary thing, you need not really go ahead decompressing the thing. It would be steroids or physiotherapy, which would form the mainstay of treatment here, right? So it depends on the time and depends on the severity of facial paresis as to what you really want to do in these patients. Another interesting thing which happens is something like this. This is what we call as facial twitching. You see this? This is an adult patient. Whenever the patient is getting any sound, the face is moving towards that particular side. This is what happens in facial twitching. Now, when does this happen? This can happen especially in patients with far advanced autosclerosis who are undergoing cochlear implantation. This is because the bone around the otic capsule, right? This bone around the otic capsule is spongiotic, right? So current would spread outside the cochlea. So it's an extra cochlear spread of the current to the labyrinthine segment of the facial nerve here, which leads to facial nerve twitching whenever some sound is given. So we need to choose our electrodes wisely. We need to ideally go for a modulus hugging electrode, which is half bended, right? Because they would prevent the electrode spread to the lateral part and therefore remain medially. However, if this does happen, the options are you go back to your audiologist and they would usually do a triphasic stimulation if it's, the company allows that. And worst cases, you need to flag off the implicated electrodes, right? So this is what I do with it's a very troublesome thing. But as I mentioned, it's usually with a far advanced autosclerosis that you land up with this. Or if your electrodes are so much out of the cochlea that is similar to the facial nerve, so obviously you need to flag off those electrodes. But it's usually the far advanced autosclerosis. Now, something which is again very commonly seen, it's not even a complication, I would say, it's a problem which you may encounter. When you open the cochlea, you may have a transmitted perilimb pulsation, right? So just pulsation in the perilimb, no active egress of fluid outside the cochlea. Or an ooze, it's a mild intermittent leakage of perilymph and CSF into the middle ear, which doesn't really prolong or last for very long, easily controllable. CSF gusher is when you have a high pressure free flow, such that the CSF completely fills the middle ear cleft. And it's tough to control. You keep on waiting, it may not stop at all. And this is how the things look like. So this is what is, transmitted pulsation. If you can see the round window, this is round window exposed. Even the round window is showing some pulsations, right? You see that light being reflected. And this is where, I go about using the, pick to incise the round window. And there is some oozing which happens, right? And, you see this? This is the transmitted pulsation and a slight ooze. Obviously not troublesome. This was a patient who had a Mondinese dysplasia, IP2 deformity, right? And they can have this kind of a pulsation happening, right? So this is just a small pulsation. And what we used here was a 632 electrode, right? If you see this electrode, it really goes in, right? And you're putting it inside the cochlea, and it's a modulus hugging type of an electrode, right? I'm going to push it in slowly, and then it really goes in, and then you kind of remove this flange, which then comes out. You need to make these white marks meet, and then you remove the flange, right? So this is what you need to do with classical, right? So this is what you need to do with your transmitted pulsations. CSF gusher is something like this. You open the cochlea and you have this CSF which is filling the whole middle ear cleft and completely coming on, filling it again and again. And this is what you need to do with it. One, you'd want to, these are present in malformations like incomplete partition 1, incomplete partition 3, and common cavities. So one of the things is to use a full bended electrode because the nerve endings are on the periphery. You use a non-modulus again because the modulus is absent in this malformation. You need to do bigger cochleostomy so that you can seal the perielectrode space with soft tissues. This can also be done by threading the electrode through the soft tissue as we see in this particular video. Wait for the pressure to go down before you start inserting and keep tissue glue ready. Be prepared for subtotal petrosectomy if you need to be. Frankly, I have never needed to use tissue glues or subtotal petrosectomies or even, a lumbar drain for none of my patients ever, right? Now, the another thing which we are all worried about is a misplaced electrode array. This should be misplaced in a minor way because it remains inside the cochlea. Can be just a tip rollover, kinking of the electrode, loops it on its own, and a transition into the scala vestibuli. Extracochlear when it's going outside the cochlea, that's something which is more worrisome. Let's look at this. Is a beautiful X-ray, right? You see this. This is the negative image of the same. And you see this. You can even count the dots which are in the electrodes. And if I were to label this, this is the superior semicircular canal here, the lateral semicircular canal here. You have the cochlea present here. This is where your oval window would be. This is where your round window would be. And this is the whole area of the middle ear cleft, right? This is how beautiful your X-rays can be. This is the Townes view. That was a modified Stenvers view. This is a Townes view, which really shows us the presence of implant on both the sides. You can compare both the sides in this particular view. Now let's look at this. If you have a suboptimal insertion, right? Suboptimal can be an insertion which is inadequate or incomplete. You see this is not going completely inside, or an over insertion. See, this is where the round window is, and look at how deep, this has gone curved and curving on so much. It's almost gone to the apical turn here, right? So this is very deep insertion. So both are not good. This can be misplaced outside now. Like, look at this. Look at this. You don't see the smooth curvature which an electrode should take, right? So you have these misplaced electrodes which are showing the kinking, and this may present anywhere. Just to confirm this, you will actually need to get a CT scan. Another thing which you need to remember is, if this is your C arm, it sometimes looks, it's such a well-placed electrode area. This seems to be in the superior semicircular canal. This seems to be so well placed inside the cochlea. However, the C arm images can be rotated. So in reality, it was something like this. This is where your cochlea was. The patient's electrode have gone inside the vestibule and have curled upon itself, giving the misconception that it was subtending a good curvature and lying in the cochlea. However, it was not, and lying in the vestibule. This is how tip fold over looks like. The last 2 or 3 electrodes folding on the cochlear electrode itself, kinking inside the cochlea, kinking inside the cochlea, kinking inside the cochlea. As you can see, all these kinks which are present, which can give a suboptimal outcome later on. Now, what can go wrong? These are the various places it can be placed: carotid canal, eustachian tube, facial nerve, vestibule, internal acoustic canal. Now let's look at this particular case, right? This is a patient, 60-year-old female with progressive hearing loss for last 15 years, right? She was diabetic and hypertension, poorly controlled, underwent cochlear implantation on 24th November 2015. The notes mention cochlear ossification, incomplete electrode insertion, short circuit in 2 electrodes, and a E-cap threshold for obtaining electrodes 6 to 11. So we had 6 electrodes which were functioning. This is how the patient presented. This is the photograph of the intra-op E-cap threshold which were tested during the first surgery. The post-op X-ray obviously showed something wrong, and the patient was not improving, right? So this is what you need to realize it. In fact, in otoscopy, there was also a posterior marginal perforation. What a CT scan done when the patient came to me, and you see this electrode going right next to the basal turn inside the carotid canal. Luckily, the carotid itself was not injured. It was present between the carotid artery and the bony carotid canal is where the electrodes were inserted. So if you look at this, the axial sections, this is the electrode going into the round window area, into the basal tunnel, and that's where the electrode 6 to 11 did show some response, and then exited the cochlea. So the surgeon actually drilled through the cochlea and went inside the carotid canal, right? And this is where it is present, inside the carotid canal area. And this made all the difference. Now the patient's electrode were lying in the carotid canal. The patient could not afford any other electrode. What you need to remember is, if you're drilling in the area of the cochlea, wash it very well so that you don't let the bone dust occlude your view. At the same time, don't drill more than 8 millimeters depth, right? Because that's where you land up with issues like going into the carotid canal. Let's look at the video here. So now we went and explained the patient that we'll give it a try using the same electrode. Look at the kind of fibrosis and neosteogenesis which has happened, right? I'm trying to dissect this fibrosis of preserving the implant, reaching the posterior tympanotomy, but it's really adherent there. I don't want to damage the carotid canal, so I was trying to dissect it off very gently. Yeah. And then finally, the electrode came out. Obviously, it's badly kinked. I'm trying to straighten it up, right? This is the, those electrodes which was very difficult to manage. And then we went inside and enlarged the cortical mastoidectomy, which was done, right? The patient, remember, had a posterior marginal perforation. The basal turn was already meddled with, during the first surgery. So I couldn't get a lumen in the scala tympani or the scala vestibuli. Ultimately decided, because that was drilled through in the last surgery. Ultimately, we decided to go through the middle turn, right? And elevated tympanomeatal flap, we had to repair the perforation anyhow. This is what you see is you're going perpendicular in about 2 millimeters anterior to the oval window, so perpendicular down, and that is where you get into the middle turn, right? Right inferior to the processus cochleariformis. Threading the electrode through the posterior tympanotomy and ultimately putting in one electrode by, one electrode inside the cochlea. And this is what happened. We got 16 electrodes which were functioning, which was phenomenal for a Middleton cochleostomy. You look at the CT scan. Basal turn, not occupied by any electrode, right? But you have all the middle turn which is having the electrode. This is where it's entering the middle turn. You see this? Entering the middle turn, right? Now, other problem which can happen with implant is a long-term thing. Now, as the implant program grows older, they're going to be patient with failure of implant. Now, this could be failure in terms of hard failure. When the implant stops functioning, we can confirm this on integrity testing, which is company specific, or soft failures when the performance just decreases. And it's diagnosed by our speech therapist, habilitationist, on the basis of their clinical skill. When they see the patient has suddenly stopped performing well, this does not show anything on integrity testing. The patient just stops performing well. Now, use the same company and the same model. If you have to do a reimplantation, you want the same model or at least a model which is electrode which is thinner and shorter. You don't want a longer or thicker electrode because that's where the problem starts. Because this electrode, once it has been in the cochlea for some time, kind of has a capsule around it. And now you cannot go deeper than the previous surgery. So you want a shorter or a same length electrode which should be used, right? And importantly, do not remove the first electrode cochlear implant till the second implant is in bed, right? So what you mean is, we'll see in the surgery also, we place the second implant and then you remove the first electrode of the first surgery out and immediately put the second electrode out, because you do not want that capsule to collapse, right? And this is what is important. Now, this was an interesting surgery. The patient underwent surgery at some other center, and then post-trauma, the patient had an issue with uh, the failure. There was a heart failure. Now, obviously, patient could not afford one, and the patient was sent to our center. So this was a metal implant, but we had the tender of advanced magnetics. So we had to put in advanced magnetics, which you never want, right? As I mentioned, we want to use the same company, but this was a different thing. Right? We had a different scenario here. So we made a different bed for advanced magnetics, removing the soft tissues here, trying to keep the electrode inside, enlarging the cortical mastoidectomy, right? And then we'll go towards a posterior tympanotomy. Now I'm widening it, and then in some time I start realizing that my electrodes are actually out of the cochlea. And this is something which I never want, right? And this is what can happen in a surgery, right? And now I was like having this issue of getting the lumen inside the cochlea. Because as I mentioned, there's this capsule inside the cochlea which has now collapsed. And I'm not sure whether I'm going to get a lumen inside or not. I'm going to put in a new implant and I may not really get any lumen. So it may not even get inserted. What I'm doing is I'm using the old implant right now. Trying to put it in so that I can actually be sure the later inserting the new implant. Now we open the new implant. So this is, this is your advanced magnetics placed. This is your metal placed. And now I remove the first implant and I immediately insert the second implant. This is what I should have done earlier also. I never want the electrode to come out, right? And now this electrode is completely inside. Luckily for us, we could actually save this, right? So this is what can happen. Now the other dreaded complication is sterile surgery. However, you may land up with infections like these. You can have various types of infections, the skin reactions, which may be complete exposure, or mild involvement of the skin. If it's a very severe infection or an exposure, you may land up with an explantation, right? And we actually went about dividing this. We have a tertiary referral center in this part of the country, and we had a lot of patients who have been operated here and there and referred to our center with some complications. Now, we divided these into grade 1, 2, and 3, and 4. Intermittent swelling, swelling with pain and discharge, but intact skin, and then complete extrusion. And then we divided it in these are the various types. You can have just a small inflammation or seroma type of picture, purulent discharges, and an explantation. And we manage these as per the gradings which were required. Now, the ideal thing would be, if you have an implant which is exposed, you should do a cochlear implant in the opposite ear. However, the issue is with the government funding and all, or the philanthropist funding, you may not get a second implant. And we need to try to save the first implant. And this is what we tried. We need to treat the concern that we may not be able to do it really well. this is the new bed which we'll make. This is the present bed which is already there, right? This is the kind of a big flap which you elevate. Please don't just excise this and you give this incision, elevate the flap inferiorly, and then elevate superiorly based biofilm, right? All the biofilm, you see these slimy areas are all biofilms. You need to remove those inferiorly. So this is when you place the, after proper washing, you place the implant here, cover it up with this flap, and then ultimately suture this up. And this may heal if you're lucky enough. Now we have done more than 8, we have done around 13 cases. And what we realize is if this is because of trauma or entirely displaced implant, it may actually be a better chance of survival. And these are the places where we have been able to salvage. Person can be salvaged, but I would still give it a try in all our patients. Displaced magnets, right? Look at this, and this is how it's getting displaced, right? And you see it's much more beyond inferiorly placed. The patient was not able to use the implant at all. And then you have this kind of incision which you give over the receiver emitter package, just superior to it, and then go about removing this implant from the magnet from its pocket, which is already outside. Right here we just hold it with non-magnetic forceps and then place it inside the pocket which is supposed to be there, right? So it's a very straightforward surgery. You just need to know the tricks how doing those. Now this is the last case, which is a very interesting case, in which we had the right side cochlear implant done about 2.5 years ago. Patient was doing well, however had an intermittent pain and mild swelling in the posterior superior part of the implant side. And look at this, after 2.5 years, this is what was present inside the body of the patient, right? This is what we can actually land up with, and this is we need to be careful to count the number of instruments. We don't have any further records, didn't keep them intentionally. And lastly, you can have chronic otitis media post implant, which can be a safe or mucosal, and unsafe or squamosal. Obviously safe or mucosal, you can just go about doing a tympanoplasty. Unsafe, you may need to explant, and I would say it's usually because of the tunnel of varia technique or a very thinned out injured annulus and the posterior canal wall if you're doing it in posterior tympanotomy. And the epithelium would therefore grow towards the posterior tympanotomy and not through the normal route of adic posterior superiorly into the editus area. And this is what we would usually find. It's usually a surgical issue which can be seen. Let's look at this video before we end. This is the electrodes which are placed, and right into the external canal wall. Look at this. I mean, the whole electrode has got extruded. Obviously, this had to be explanted, and we went about explanting this. And this patient roaming around, operated some other center, roaming around for last 3 years with this implant hanging outside. Look at how callous people can be. I mean, it's not just obviously it's a surgical issue, but sometimes the patient really don't worry about it. Right? This is what they've kept it out, and we just went about explanting this in local anesthesia. At the end, the take-home message is never celebrate too early. Let's look at this video. So never celebrate too early, right? That's what the goalkeeper here. Never lose hope too early. Look at the striker here. And never leave the patient till the job is over. And this is what we need to remember. Cochlear implant patients are going to be with us for their whole life. And that is where we need to be more careful, more sensitive towards them. Let's not be celebrating too early. Also at the same time, let's not lose hope too early. Thank you so much for a patient listening. And if there are any questions, we can take those now.